some patients were Google patients, let me put it that way. They'll go to Google and see this and this and this. So when they come to the hospital, they'll tell you, I have a cough and I don't have a fever. I have a headache and I don't have this.
I think in a way, COVID was a blessing in disguise for Africa. Because I think we had also slept for too long as a continent. So COVID woke us up.
1 week you were 10, the other week you were 5. Nothing was done in between. You had to work for the 10 that were not there.
Personal protective equipment. Many countries did not have gloves. Uganda inclusive, we were never manufacturing gloves. We were not manufacturing aprons. Now we manufacture aprons. We have never stopped manufacturing aprons and gloves. Now imagine we couldn't even do this before COVID.
Prof, when you talk about public health institutes, you're talking to us because maybe we understand some of these things. But for people out there who may not understand, what is a public health institute? What is a public health order? And how does this entire system work and help protect public health in any given country? Could you just give a sneak peek into this entire system for ordinary citizens out there who are not in this space to get an appreciation of the work that you lead on as the president of this network?
National Public Health Institutes are actually at the center of ensuring that the surveillance systems work, ensuring that the response systems work. They are actually the frontline responders for countries. They're the ones who have their foot on the ground, or the moment you declare there is an outbreak, they're the ones who reach there first.
Okay.
And then they don't only reach there, but they generate evidence, and then that evidence is the one that is used to inform decisions of the country. And if they are not during the peace times, they are actually generating evidence in many ways because they look at all the data systems. Like, of course, DHIS2. DHIS2 is the data capture systems for countries, where all the information about diseases actually are entered into from the health facilities and from the community. And they are captured in that DHIS2. So they analyze data from that DHIS2 periodically because that is where the diseases are. So they understand the trends, they understand so they pick alerts of where there are possible potential outbreaks coming. So in other words, National Public Health Institutes are equipped to actually ensure that the countries are safe, the security of the country is okay, they monitor borders, they monitor everything. So they set up systems which actually guard the national health security of the countries. And so if you this is a tested model which has actually worked because it's so different from the academia. Academic institutions do research. When they do research, they put it on the shelf. It is very rare that it reaches policy briefs. So actually, National Public Health Institutes, in all that they do, they link up evidence generation to policy formulation to action. And then they actually even ensure that they give options to the ministries. The options they give to the ministries is that we are giving you 3-4 options. But this one is economically viable. This one is not economically viable. This one here is going to take a longer time to implement. So National Public Health Institutes go through all those things. They do a lot of synthesis of data to ensure that actually countries respond in the right way. And that has actually helped countries. And most importantly, they incorporated One Health in all this. So they address all diseases that actually come to humans from animals or from the environment. So that is what National Public Health Institutes are. And so they have actually done a lot in all these countries. And one of the, if you look at the strategic plan of Africa CDC, one of the pillars is actually establishment of National Public Health Institutes in Africa. And so they have moved actually to ensure that all these are done. Now, one of the other things, of course, when you look at the new public health order I talked about, one of them is strengthening public health institutions. So it's in the new public health order. So the new public health order was like saying, we need to come up with something that is going to be a game changer for Africa. So that's why the new public health order was actually coined. So one of them, of course, is that strengthening of public health institutions. The other one is mobilizing resources domestically to ensure that domestic resources are actually put in the health systems to strengthen not only response, but also to strengthen other aspects of the health system. And then, of course, the other one is about the manufacturing of vaccines, diagnostics and therapeutics. So that is part of that package of the new public health order. And then the other fundamental one is developing a meaningful workforce for response and for addressing public health needs in Africa.
So could you help us understand the progress that has been made in building these institutions and ensuring that they deliver on their mandate?
So in terms of progress, actually, I can comfortably say that now we have 30 fully established national public health institutes in Africa. We have 15, about 15 now that are in the process of establishment.
Okay.
Most of them already have either had meetings or they have done peer visits, which are organized by Africa CDC, and they're in the process of coming up with documents for establishment. We have 10 that are not yet started, but there's a lot of advocacy meetings going on in some of those 10 countries, especially in the Arab-speaking countries and North Africa. But all in all, everything is promising. That's why we're saying by 2028 they should actually all established.
We are now hearing a lot of talk around pandemic preparedness, around, not being caught off guard again. As somebody who has been at the front line, what does preparedness mean to you?
As Prof had said, for them, they were mildly prepared for COVID because they had Ebola on en route. It did not get to that point. But us, we don't even have basis for Ebola.
Yeah.
So COVID was not even heard of.
Yeah.
It was a first. So for the second, we'll get maybe training on what will happen. But now it all depends with the disease that will hit us. Because maybe the other one will not need a face shield, will not need a mask, may need boots, might need gown from the word go. You enter the hospital entrance, you might need the whole suit.
Yeah.
Yes.
What do you want to tell Prof as a policy maker in this space?
I think health workers should be given the first priority. As much as people create the policies, people forget health workers are human. They want us to do the 100%. But on the other side, what is being done 100%? For COVID-19, are there health workers after the whole scenario, after the months of exhaustion, dealing with patients? At some point, COVID was a very tricky disease because once it hit us, hit our patients, their relatives were isolated. We had to do the 100%. We had to be the relative, to be the health workers. We had to be everything, comfort her, give them medicine. While the health workers given the mental counseling or what was done to the health workers at the end? Were all of them involved? Or people just assumed we are health workers, we wake up one morning and deal with our issues? Yes, we have issues, but COVID-19 took us to levels that even us ourselves were not expecting. Because at the end of the day, you'll go to your family and they'll expect a smile. But when you're at work, you're exhausted. Because as you said, there was some workers became sick. So we were exhausted. We were pushed to the point. Like maybe if you work, 1 week you are 10, the other week you are 5. Nothing was done in between. you had to work for the 10 that were not there.
So listening to experiences like Esther's, Prof, what lessons should policymakers draw about protecting frontline workers if another pandemic such as COVID hit?
Health workers are at the center of this. And as I mentioned earlier on, is that when we're preparing the countries for any outbreak, including the pandemic, we need to take all that into account. So particularly for the health workers, when we are preparing, we need to understand the dynamics around the health worker. What is it that the health workers do that would put them at risk? And then during that outbreak mode now, what do health workers do? Because there are health workers who are directly in response, but there are health workers who are providing other essential services, but they are still at risk. So you need to look at all those categories across spectrum of all health workers and say, how we plan for them? First of all, we need to look at the numbers. Do we have enough numbers? Number two, do they have enough training that is going to make them do the right thing? And then the third one is, of course, have we equipped them? So we need to make sure that health workers are well trained, health workers are equipped, health workers are skilled, they know what to do. And you provided. Then the other part which we forget too much, of course, we want health workers protected. That's okay. But we forget about their time, the time when they work. Remember, in the outbreak time, you're going to have an overtime. So have you thought about the overtime for the health workers? Because if my period of work is supposed to end at 5, am I going to end at 5 and then walk out in an outbreak period? It can't happen. That somebody must take over from there. There are people who are in the ICU. So have you taken care of all that to ensure that, health workers are taken care of in terms of rotation? Have you ensured that the rotation is well planned so that people do not burn out? Because burnout is a very common thing, especially when outbreaks take long. It's a problem. Then the major thing actually that we have to think about at the policy level is risk allowance. We need to think about actually paying these health workers risk allowance because they're at risk of getting any of these things. So all those things must come out clear from the policy perspective and ensure that during preparedness we have planned for all these things. So we were having them in the response plans. The response plans might not just be taking about aprons, about whatever, but it should take care of the whole spectrum of health workers to ensure that they are actually okay and they're human beings. They're not machines. They're human beings. So that must be taken care of, comprehensively.
6 years in, since COVID-19 first hit, what is that one lesson that we should not forget or never forget if another pandemic, or as we hopefully nothing else comes, but if ever another comes, what is that one thing we should never forget to prepare for?
I think what we need to prepare for is our mental capacity to handle it. Because, because the pandemic will hit you in directions you do not know. As much as you wake up in the morning, go to work, come back, but your mental capacity to handle it. Because one time, let me talk from a healthcare perspective. You'll wake up, have a very healthy COVID-19 patient, positive, manage. But during that duration, that patient passes on or succumbs. It is not very interesting. Yes. Because at the end of the day, you'll want to tell the relatives this and this is happening. Remember, they are not allowed to come even and visit the patient. Even if they would be allowed, it's behind such glass. So you have to be well prepared emotionally, because you don't want to break down in front of a patient. So you'll be superhuman. You'll have to be superhuman.
That's actually an interesting way to look at it, because when you said how to deal with breaking the news to, the bereaved, the relatives, it's something that we don't think about, considering the fact that they are not allowed into, hospital settings, the patient is isolated. How do you break that news? And what does that toll mean to you as a service care provider, in terms of, having to deal with these kind of losses, information, and communicating that? I think it's an interesting way to look at it. I've never looked at it that way.
It is harder for us, twice as hard, because let me call it the resuscitation. The resuscitation was very different for COVID-19. There are different scenarios. For other conditions, you're told your relative is going through this, it's gonna be all right. If the condition changes, you're allowed to see. But COVID-19, from the time you're isolated till the time something bad happens, you're not allowed to see. For us Africans, we want to be there. Yes, help the patient, encourage the patient, us as the relative, leave alone the medical personnel. But that time, then make it worse. You remember when this, the COVID-19 barriers, if I may put it that way, were they even allowed to see?
No, I don't
don't think so. Actually, they were not.
No.
It was even the people dressed in those gowns doing the final rites.
Yeah.
In African communities, we do not know that. We know seeing, doing the whole thing, then having
Touching.
closure. For COVID-19 was very hard. Everybody. Yes. And you being the health personnel, you have to be the helper. Is not interesting, even for other diseases. But COVID-19, it was not a joke even to the mental.
It took a toll on mental health.
It took a toll on everybody, yes.
Prof, as we wind up, I'm going to combine two issues in one. And I'm wondering, if a pandemic were to emerge tomorrow, is Africa prepared?
Yes and no. Yes, in that we are better prepared than we were when COVID struck. No, in that we still have gaps. But there is hope. There is hope that we're in the right direction. And for me, what we need to do, just as you mentioned preparedness, we need to prepare. And that's the key thing. That's the key word. We need to be proactively prepared, not reactively prepared like these firefighters. We need to be proactively prepared. And proactively prepared, that means all the pillars of response must be ready to respond. So that means we need to have very good coordination structure without overlaps of roles. So once we have a very good coordination structure, once an outbreak strikes, you know who is supposed to take decisions, you know who is supposed to do what. That is a clear coordination and response structure. We need to have all these other pillars of response. Case management, it must be well prepared to manage the cases, including ICUs. We need to have them available. Remember how we constructed them in a hurry during COVID when people were outside. If I tell you how I was called, the response team that were brought from the field were outside and breathing badly at 1 a.m. because we had to offload some people from. Now tell me, ethically, as a medical doctor, there's somebody already in the ICU, but he's not a responder like the ones I sent to the field. And now they are calling me at 1 a.m. that there's somebody already outside. Do you offload the other one and take yours inside? You can see the dilemma you are in. But we are saying all those must be well prepared. Then, of course, the rapid response team. The rapid response team must be well trained. And remember, I gave you an example of a tortoise. The kind of workforce, public health workforce we are building now should be like a tortoise. When you throw in the water, it swims from any angle, whether backwards, whether in front, whether it falls from the edge. That's the kind of workforce we need, not those who get lost. So we must have all those. And then, of course, we must have our diagnostic and vaccines well prepared. If you look at the public health order, unpack it. So we need to prepare and have all these things. We need to have the stockpiles ready, the countermeasures ready. And then we say, once it strikes, we are not going to run around. Then, of course, fundamentally, we need to have money. We have to have public health emergency response funds which are ring-fenced. It must be ring-fenced. There is nothing like saying that you have this money in the account of the Minister of Health, zero. But of course, once it's in the National Public Health Institute, you know it's safe. So if we move towards, of course, having National Public Health Institutes functional, for me, that is it. And that's the one I'm going to wind up with. We must have fully established and functional National Public Health Institutes. It's the way to go. Yeah.
Thank you. So as we close this episode, I just want to give Esther one parting shot to give our audience, just one in 1 minute, so we can close this discussion. Yeah, what is your parting shot to the audience in relation to preparedness for in the event we get another pandemic tomorrow?
At the end of the day, it's teamwork. We'll get support from the funding, as Dr. said, the policies, but at the end of the day, we are the people on the ground. So we work with what we have. Yes.
Thank you very much. And I would like to bring this discussion to a close. But as we do that, this is just a reminder to you, our audience, that we dealt with COVID-19 6 years ago. We don't know when the next pandemic will strike. We just need to be ready. And wherever each one of us is, we just need to play our part. So thank you to frontline workers like Esther for bearing the brunt of the pandemic, getting exposed herself and going through this firsthand, but really serving patients and making sure that they get well. And to you, Prof, for taking lead in trying to establish systems in place that are actually getting us to that level. So we look forward to our next conversation, but for now, stay well and stay blessed.